You walk into chaos, alarms are going off, but you've got this. In this video, I'm giving you 8 rapid fire tips every new ER nurse needs to know to stay sharp, safe, and confident at the bedside. I'm an ER nurse myself, and I created a book and online course to help new nurses like you get up to speed faster. You can find both links below. For the first tip, what are the characteristics of atrial fibrillation with a rapid ventricular response on an ECG? And why is it considered a critical condition? This is something you're going to see frequently in the ER, and understanding it can help you act quickly and effectively. On an ECG, you'll notice no distinct P waves, you'll notice fibrillation waves, and the rhythm is irregular. There's no consistent pattern to the R2R intervals. In atrial fibrillation with RVR, the heart rate is over 100 beats per minute, but we don't usually start worrying or seeing symptoms until the heart rate reaches well over the 120s. Having a good grasp of the care of afib RVR is very important, as the atria are quivering instead of contracting, which reduces overall cardiac output. Combine that with a rapid ventricular rate, and the heart doesn't have enough time to fill properly between beats. That can lead to hypotension, shortness of breath, chest pain, a sensation of palpitation, and even heart failure, especially in patients with underlying cardiac issues. On top of that, AFib increases the risk of blood clots forming in the atria, which can lead to stroke. So quick recognition and treatment are essential. So remember, no P waves. You're going to see fibrillation waves between QRS complexes, and irregular with no consistent R2R intervals. For the next tip, what is the antidote for a Tylenol overdose, and why is it so dangerous? This is a must-know for any ER nurse, especially since Tylenol overdose is one of the most common and deadly poisonings that we see. The antidote for acetaminophen overdose is acetylcysteine, or NAC. It works by replenishing glutathione, which helps the liver detoxify the harmful byproducts of Tylenol. So why is acetaminophen overdose so deadly? It's because in large amounts, it gets converted into a toxic metabolite that kills liver cells, leading to liver failure and even death if left untreated. The tricky part is that symptoms can be mild or even absent at first. Patients might look fine, but their liver is silently being damaged. That's why early treatment is critical. Always check a Tylenol level, but make sure that it's drawn at least 4 hours from ingestion so that it's an accurate result. Again, as an ER nurse, prioritize an acetaminophen overdose to make sure that there's no underlying liver damage occurring. And just remember that for the most accurate result, you must draw the Tylenol level 4 hours from ingestion. For the next tip, how long after a patient presents with a brain bleed is the head CT typically repeated, and why do we repeat it at all? Most hospitals follow a 6-hour window to repeat the CT. The reason, it's to monitor for any expansion of the bleed, especially in patients who are at a high risk, like those that were on anticoagulants or those who've had recent trauma or elderly. If the patient looks stable at first, bleeding can, however, worsen over time. That's why we don't rely on the first scan. We repeat it 6 hours from the initial to make sure that it's not getting worse. You're also going to be watching closely for any neurological changes, like a drop in level of consciousness, pupil asymmetry, or worsening neural exam. If the patient worsens before the 6 hours are up, a CT is immediately obtained. You go at that moment in time. And that's where you, as an ER nurse who are constantly monitoring and assessing your patient, if you notice something is changing, you communicate to the team and you will be obtaining a repeat CT at that moment to evaluate for a worsening or expanding bleed. The repeat CT is a safety net to catch any deterioration early and then guide further treatment if needed. Now, let's go over quick and effective IV tips. You need a leg gravity help you. You place the tourniquet at least 4 inches above where you're going to be going to poke. Drop the arm to allow gravity to fill the vessels up. Again, let gravity help you. Place the tourniquet, drop the arm, have them squeeze, and let just gravity fill the veins up so that they're easier for you to see and to feel. And the next thing is going to be you need to give the area in the veins good love taps, meaning you need to tap in really well so that the irritation from the tapping gets the veins to pop out more. I know the nursing schools are going away from this, but in the heat of the moment, in real life, good taps actually do make the veins pop out more. And if needed, you also need to add a second tourniquet to help do the trick. You can also ask the patient where they normally have IVs placed. The difficult patients typically know where they have a good, decent hidden vein, especially if you work in an area that has a lot of drug users. A lot of them, if you ask them, hey, where do you have good veins at? Or where do they typically get veins, get IVs in you? They're going to know exactly where to go. And then don't forget, when looking for veins, you have to know your anatomy. Remember your AC veins, the medic vein, remember the veins on the hand and even on the wrist. And in an emergency situation, you place the IV where you can. We don't worry about the joints and so forth when the patient needs life critical saving situation. Just get the IV where you can so you can stabilize your patient. For the next step, how often are chemistries repeated in a patient with DKA, and why is it so important to monitor them closely? In DKA, chemistries are typically repeated every 4 hours. As you give insulin and fluids, electrolytes shift rapidly, especially potassium. Insulin pushes potassium into the cells, which can drop serum levels dangerously low. You are also watching glucose, bicarb, and the anion gap to track how well the acidosis is resolving. These frequent checks help guide the treatment, whether you need to adjust the insulin, the fluids, add potassium, or transition from IV insulin insulin to subcutaneous when the treatment requires it when the gap is closing. So again, for DKA, you should be repeating the chemistry every 4 hours to keep an eye on the electrolytes and to keep an eye on the glucose, the bicarb, and the anion gap. For the next tip, what does a lactate level tell us, and why is it such an important lab in emergency care? You'll see this ordered frequently, especially in sick or septic patients. Let's talk about what it really means. So lactate is a powerful lab that tells us a lot. When cells don't get enough oxygen in blood, like in sepsis, shock, or cardiac arrest, they switch over to anaerobic metabolism, and that itself produces lactate. So an elevated lactate level means tissue hypoperfusion. The organs aren't getting what they actually need. They aren't getting oxygenated, rich blood. A level over 2 is concerning, and over 4 is critical. It's a red flag that something serious is going on. We also use lactate to track progress. Is the perfusion getting better or worse? That's why you'll often see it repeated after treatment begins, so that we can gauge whether our treatments are actually working or not. For the next tip, tip number 7, which conditions should make you pause and think before giving IV fluids, and why can IV fluids actually make things worse in some patients? So not every patient may benefit from a fluid bolus. So let's talk about the conditions that you need to be more mindful of before just hanging up that liter of NS or LR. Some patients, again, can actually get worse if you give IV fluids too quickly. So here's who you need to be extra cautious with. The first is always going to be heart failure. The heart can't pump effectively, so adding volume can cause fluid to back up into the lungs, leading to pulmonary edema and overall sending them into a heart failure exacerbation. And then there are also patients with renal failure, especially those on dialysis. Their kidneys can't remove extra fluid. So what you give will just stay in the body. And if you give fluids, you're going to be increasing the blood pressure and causing swelling and respiratory issues. Again, for patients on dialysis, if you give too much fluid, it's just going to stay in their body and it's going to increase their blood pressure. It's going to go into their lungs and just create all these other issues for them. And then lastly, also remember patients with liver failure with cirrhosis, fluids shift into third spaces like the abdomen due to the low albumin levels. These patients are often intravascularly dry, but physically overloaded. So giving fluids can be tricky and even harmful sometimes. Always pause and assess volume status before giving fluids. If these patients are needing fluid boluses, your provider will most likely start with a smaller dose, smaller amount, and then reassess to see if they could tolerate a little more. For the next tip, which cardiac rhythms require defibrillation as part of the treatment? It's in high-stakes situations in the ER, knowing when to shock and when not to shock is critical. So let's break it down. There are going to be 2 rhythms that require defibrillation as part of emergency treatment. The first is pulseless ventricular tachycardia, a fast but disorganized rhythm with no effective cardiac output, with no pulse. The second is ventricular fibrillation, a chaotic quivering rhythm with no organized electrical activity at all. Both are shockable and need immediate defibrillation to give the heart a chance to reset and regain a normal rhythm. But remember, not all cardiac arrests should be shocked. PEA, pulseless electrical activity, and asystole are not shockable rhythms. Those require, again, just high quality CPR and medications, not electricity. The only ones that we're shocking, again, that we're defibrillating are going to be pulseless ventricular tachycardia and ventricular fibrillation, because as you know, early defibrillation gives your patients the best shot at survival. The ER can feel overwhelming, especially when you're new. I know how tough it is, trying to keep up, worrying about making mistakes, and feeling like you're always behind. That's exactly why I created these resources to help you gain confidence and take control faster. Our book is your go-to guide for essential ER knowledge, designed to give you exactly what you need without the fluff or overwhelm. It covers the most important ER concepts, including triage, ABCs, advanced life support, and critical emergency conditions and their treatments, all explained in a clear, easy to digest format. Our course includes the book and takes your learning further with step-by-step video lessons, efficient charting strategies to protect your license, and practice tests to reinforce your learning. It also includes real-world scenarios to sharpen your critical thinking and decision-making skills so you're prepared for high-pressure situations. If you're ready to feel more confident in the ER, grab the book or enroll in the course today. Links are in the pinned comment and description below. And as always, teamwork makes the dream work. And here at Emergency Chaos, we are proactive, not reactive.